So always try to look for, because I have certain images with me. If I remember, I'll bring it for you. AP view, everything looks normal. When you see a lateral view, one bone is going north, one is going south. But in anterior posterior view, it all looks fine. So this is what is happening. There's a pathological fracture and all that. Now what's wrong? Dislocation, my dear. Wallahi, I can give you a free ophthalmology appointment. Go and check your glasses. You need to change your... Guys, there's a big disc fracture. Can you see that? If you see this dislocation, wallahi mushkila. Then I failed teaching you. Now, with this fracture, who is involved? Now this is the root value, please. You see, there are, as I told you, there are 600 different books for anatomy. Every book has to sell his edition. So they bring up little bit differences. Don't get in that. If I sit down and try to teach you brachial plexus, I need more than 6 weeks to finish brachial plexus. That much is there. So don't burn your hands. Just go with one small simple segment, because you have so many other things to finish. So simply remember radial nerve C5 to T1. Now this much if you know about a nerve enough. Where it begins, I'm talking main nerves. Where it begins and what are the different branches given, which muscles are innervated in axilla, in the upper arm, in the forearm, in the hand. That's it. Nobody needs you. It goes medially, it went laterally, gone superiorly, inferiorly. It's too much. Nobody is concerned with the courses. But simply remember this. Now, keeping this image in mind, we all agree with the mid-shaft fracture, radial nerve got damaged. Now, my concern is what? Radial nerve is damaged. And question will never come like that. A person came with radial nerve damage. What are the branches? And no, sorry. A 20-year-old young man presented in ER after a history of trauma. X-ray revealed mid-shaft fracture. That's it. And examination findings are a wrist drop. Now you have to figure out who causes wrist drop and mid-shaft fracture, who's at risk. Now the questions will be A option, which of the following nerve might have sustained this injury? Posterior interosseous nerve, ulnar nerve, median nerve. So like this. So this is an MCQ. It's a gift for you. So now a question is, and then there's a tagging, but this person, question is not complete yet. This person has still, someone 20-year-old presented in ER with a mid-shaft fracture, examination revealed wrist drop, but he can still extend his arm at the elbow, and a weak extension is still possible at the shoulder. So it means what? Which muscle is still surviving? So tricep is surviving, and we learn that tricep is supplied by the radial nerve, and we say that it is damaged. So how is occurring?
So the proximate part of the radial nerve is there, but
obviously mid-shaft fracture proximal part has to be there. But how this? My question is what? What are the factors which maintains weak action, which are still possible at the elbow joint and the shoulder joint? Yes. La. Hold on. Let me make your life easy. The water which we used in hammam, it's coming from the sea of Dammam. Is that right? For Riyadh. They pump it, not probably, it's for sure. Go and, if you want to take a tour through swimming, I can push you there. So this water is pumped from there, and then it reaches to different areas. God forbidden, if this line is broken for any reason, will you get the water? So there is no proximal supply, my dear. And before that, like say this line is broken at Qasim somewhere. So before Qasim, all of them are getting water. But after Qasim, nobody gets water. Unless they repair it or they make some other arrangement. So now, keep that concept in your mind. Look at this radial nerve. Answer was in front of you. Radial nerve gives branches to the triceps in the axillary region. Long head and medial head. And then again it gives branches in the mid shaft to the lateral head and medial head. So medial head is dead. Lateral head is partially surviving, but still medial head has supply in the axilla and long head has no effect. So still we can bring weak extension at elbow joint because partial injury. But if radial nerve is damaged here, the story could have been different. And if radial nerve is damaged here, there was nothing wrong with the tricep, but these will be affected. If radial nerve is damaged here, this sensation is gone. So try to anticipate after the injury those structures. So this schematic diagram is very good for that type of understanding. If I damage my nerve at this line, so all these muscles will be affected. All this sensation will be affected. If it is only damage here, I can damage, these muscles will not be working. If it is damage here, down muscles are not working. Is that clear now? Can you correlate the things? So this is what our exams are. Obviously. There is no second thought in that. And remember, any nerve who crosses a joint must supply that joint. Any nerve who pierces a muscle must supply that muscle. And any muscle who crosses a joint must bring some movement to that joint. Maybe a weak movement or maybe a strong movement. It depends upon the strength of that muscle. Is that these three concepts will remain throughout your life when you talk of movements. No matter year 1, year 3, year 5, or you pursuing your career as an orthopedician. Going further, we left at this place. Now let's bring the muscles. And we learn this muscle is very important again. And we know that it emerged through two heads. One head is coming from supraglenoid tubercle. This is the long head, and the short head is coming from the tip of the coracoid process. So I have supraglenoid tubercle and tip of the coracoid process. Short head which lives medially, long head which lives laterally. And they are coming from these 2 points. They meet together, they merge together, they come down towards the radial tuberosity to get attached onto the radius. This is a very powerful muscle, very powerful supinator of this joint. This is not elbow joint, this is proximal radio-ulnar joint. And it's a strong flexor of my elbow joint. And it is a weak flexor of my shoulder joint. So you need to know action like this. If you are lacking, if you simply say, oh, it's flexor, where? I don't know. That's not happening.
Isn't the long the biceps synovial?
Subar is all coming, all coming. So now, this becomes a tendon, and now these tendons are important for something. Why they are important? Someone has a stroke. I hope everybody understands what is a stroke. Tell me, what is a stroke? Really? Come on, man. Someone suddenly high blood pressure, there is some damage and unable to move his body, just lying in the bed, maybe mouth half open, cannot close it, cannot move his hand. This is called stroke. There's an injury in the brain stem, maybe to the spinal cord. Now you are re-evaluating this person. Now before we agree, this muscle was, I said, it was flexing here, it was flexing here, and it was supinating here. Now this muscle, now this person has a stroke. Now I want to check what is the extent of injury, up till which part of the spinal nerve is, spinal cord is affected. So I'll tap here, I'll bring a hammer. I'll bring a hammer like this. Have you seen doctors carrying these type of things? They hit it. Why they hit it? By hitting, because this muscle is not moving. By hitting here, you can see some impulse generated here. So if impulse is there, and if it's a good impulse, you can say that C5 and C6 spinal cord level is fine. I can see an improvement, till C5, C6, it's starting working again. But still it's not achieved fully. Are you with me? This is checking a reflex at spinal cord levels. This is not spinal nerve. Clear? And this is an easiest way. Those people who has weakness, who have loss of function, we can assess how much is the degree of loss and which segment is gone. Going further, you're asking about this transverse humeral ligament which maintains this long head of the biceps in the bicipital groove. If this is damaged, this long head find running around, and this is the condition in the red box. Now there is a special modification. There is a deep fascia here, a thickening, and that thickening is given a name of bicipital epineuritis. It helps us in bringing supination at the proximal radio-ulnar joint. And under this bicipital epineuritis, I have my brachial artery accompanied by median nerve. Is a pressure point. You can record pulse here. When you check blood pressure, you put the cuff of your apparatus and there is a circle made. Always keep it medially. You are targeting directly on the brachial artery, and you are recording blood pressure at this place because it's easily accessible. Yes, my dear.
The bicipital is it like a ligament?
Yeah, it's an extension of this. It's a very strong membrane, which this make it a very strong. Once you will dissect this cadaver, you'll see on cadaver, you can anticipate how strong is this membrane. It's not just a loose membrane. It's a very tight fibrous sheet. And this is my median nerve. We all agree to that. And these are the actions of the biceps. So the first action is a powerful supinator of the forearm. At which joint? Proximal radio-ulnar joint. An efficient flexor of the elbow, and then opens a bottle of wine. Fine, you are not doing it, so you don't know it. Ignore it. So, going further, we were talking about a muscle, and I said this muscle is very interesting. Brachioradialis. We love to ask about this muscle. Why? It emerged from the lower arm. It lives with the extensors of the forearm. It gets its supply from the extensors of the forearm. It is extensor of the elbow and is an extensor of the elbow and the wrist. But this muscle is giving us flexion. How it is giving us flexion? When you are shaking hand with someone, when you are chopping, when you are playing badminton, table tennis thing. So, in this position of your hand, where your thumbs up, this is mid-prone position. In mid-prone position, brachioradialis act as flexor. If my hand goes like this, it is a weak extensor. If it's like that, it's a flexor. So if somebody put a question, someone has an injury to musculocutaneous nerve, but still can bring flexion at elbow joint in mid-prone position. Name the muscles responsible to bring this action, and the options can be biceps, brachialis, coracobrachialis, brachioradialis, and conius supinator. So the right option is brachioradialis. In mid-prone position, it's a flexor of elbow joint. Is that clear? So this is my brachioradialis. It comes from the lower segment of the humerus and it goes to the lower part of near to the styloid process. And again we check some impulse here. So C5, C6 and C7 spinal cord levels can be assessed by tapping the tendon of the brachioradialis. So now the deep layer, we had a muscle here known as coracobrachialis, because it's come from the coracoid process and coming to the brachium region. The arm region, another name for that is brachium, coracoid, and this is where it is attached. And this one, the most strongest flexor of my elbow is brachialis, and this going to the ulnar tuberosity. Clear? So this is the action of brachialis, coracobrachialis and brachioradialis. If you don't know about these blue lines, man, you are in trouble. Remember that. Are we clear with this so far? So let's touch upon the vessels. We know this artery. Here we call it axillary, here we call it brachial. So what is the demarcation point? My lower border of teres major. From this point to this point I call it brachial. At the head of the radius, it again further changes its name. It divides into radial, goes to the radial side, ulnar goes to the ulnar side. Make sense? Now, lateral to it I have the lateral cord, and that pierces this muscle. So musculocutaneous, if you are unable to find out, look for a nerve who goes through a muscle. That must be your musculocutaneous. So musculocutaneous pierces it, and then it supplies biceps, brachialis, and it continues as lateral cutaneous nerve of the forearm. Musculocutaneous. I have medial cord, which continues when it passes, we call it ulnar nerve, and then it passes behind the medial epicondyle. If this part is fractured, we should suspect injury to the ulnar nerve, unless proven otherwise. Now this lateral cord and medial cord give two roots, and they join to form what? My median nerve, which is coming down. And it is not supplying anywhere, it's supplying in the forearm. Is that clear? Flexors of the forearm. Median nerve. And there is a median nerve. And this place again, we check things. What we check here? We check blood pressure. Is that right? Now there are some cutaneous branches, I'm just passing by. Now, if you want to know about brachial artery, this much is enough. How it begins, where it begins, and then it divides. Remember, radial and ulnar arteries are not branches. They are terminal branches. They are not the main branches. So main branches are profunda brachii, superior ulnar collateral, middle ulnar collateral, and inferior. In your books you may find middle ulnar collateral is a branch from profunda. Don't be confused with that. Different books talks differently. And nutrient. So these are the main named branches of the brachial artery. Is that clear? What was your question, gentlemen?
Yes, in the previous debate there was a question that said fracture in the middle shaft of the humerus. What will be more able to damage, the muscular cutaneous or maybe
Musculocutaneous and? So,
what's that?
radial nerve.
The answer is
Radial nerve is never muscular, because musculocutaneous never survives with that part. It comes here, it divides, it gives branches, khalas. Musculocutaneous is gone. Even it's not going close. And in my picture, did I show you it go close to that bone? My second slide. Remember that? So there was no talk of musculocutaneous in relationship to humerus. Is this clear, guys? If you don't know this much, this is straight away one question. This is a picture of the same thing. Same concept. Now again, summary of posterior compartment. So we have here one muscle, and that was my triceps, and its nerve was radial nerve. I talked about it, so I don't want to put words for that, but we know that triceps 3. So it has a long head, it has a lateral head, it has a medial head. So where I have my long head, it goes to infraglenoid tubercle, and it goes to this process, Olker-Nov. This is my long head of tricep, infraglenoid tubercle. This is my lateral head. And then middle head is a deep one. It's not superficial. So this is I'm showing you two heads of the triceps. Now we can check reflexes here. C7 and C8 can be checked. So I am not checking the whole radial nerve by tapping at this tendon. I am only assessing C7 and C8 level. So now this is my anconeus muscle, a very small one. Now what is this muscle, guys? Why minor? Now can you see your quadrangular space, upper triangular, lower triangular? Can you figure out boundaries? If you have still some confusion, recheck your confusion. What are the boundaries of quadrangular space and triangular spaces? And we know the contents. Who is this muscle? Who is this? Very good. It shows you guys are in line. I can hope good. I disregard my comment for foundation. I can still hopeful for you that you can have. I can still see people can score good in MSK, inshallah. So my quadrangular space showing me one artery. What can you name it, my dear? So learn to say it complete. And the nerve is, guys, axillary nerve. Please wake up. I just said you guys are good, so you have shown me your back. No, don't do it. Right? Now this is my deltoid. And now I'm left with my upper triangular space. Who's this dude? Circumflex. And who is coming here, guys? Profunda brachii and radial nerve. See that, Tariq, and then talk. I was showing nerve at that time when you said profunda brachii. See, go back. I was showing you this and you said profunda brachii. So watch out. Don't say in excitement, nerve as a profunda. Is that clear so far, guys? Perfect. And now this is a cutaneous one. This is a cutaneous one. And this is the main one, ulnar. Now this medial epicondyle, we also call it a funny bone. Don't think this bone makes some jokes. It's just when you hit it against any table, any hard surface, you may have some electrical sensation, some funny sensation. Now let's talk about, we have not seen the medial head of the triceps. So it's visible to you, the long head. This is the lateral head. We cut it a little bit. So we want to see the medial head. As I said, is a deep part, deep layer. So this brown thing is the medial head of the triceps. Clear?
But doesn't appear to be crossing a joint.
Which joint? My dear, they all, can you see that? Brown, this light red, this dark red, they become one tendon.
Wow. They're all in.
I have a good friend who do good eyesight checkup. He will do free for you. Be my guest, take my card and you'll get it free. In Salman Al Habib, Al Rayyan. Who's name him?
What?
Name him if you know. So fine, I agree with you. You are not able to see it. They all, like all tricep, like bicep, all the heads they become one, and then they all become a tendon. We call it a tricep tendon, and it goes to one common place. Is that right? So now you have seen the medial head. We know about these vessels. So now let's proceed with. We know the action of the tricep, powerful extensor of the forearm at the elbow, and assist in extension of the arm at the shoulder. So now we know this. This is muscular person. So there are visible veins. These are not varicosities. Okay? Yeah. We call them now. They are not varicosities. Varicosities, it's little bit tortuous. It's not straight. If you see a vein under the skin and if it is straight, never call it varicosity. If it is tortuous, going like this, some wavy zigzag, that is varicosity. The normal vein appears with normal outlines. So this is under the skin. We remove the skin. This is what is inside. This is where when you donate your blood, people put the needle here and they take the blood out. Right? So this area is famous. We call it cubital fossa, and there you can see its boundaries. You can see brachioradialis, you can see pronator teres and its contents. These are the details. You are expected to know this much. It's bounded by proximally what, laterally what, medially what, roof and floor, and then what are the structures present in this cubital fossa. Now, coming to the last part of my presentation, that is about the elbow joint. I'm happy, yesterday it was done. So, we are looking at laterally at elbow joint, medially at elbow joint, and from the front at an elbow joint. So now, labeling, I hope everybody understands. There is no fun in that. We talk about it 3 times today. I'll keep on pushing till I reach where I want to see. Now, for any joint, what you should know? What is a must-know information for any joint of the body? First, what type of the joint? So, it is a synovial. Which variety of synovial? Hinge type of synovial. What type of joint? What are the ligaments acting on this joint? And what are the actions brought about on this joint by different set of muscles? So if you know these 3 answers, you are set. If you know the repair of ligaments or you don't know the repair of ligaments, it's not your level. You are not in phase 2 or phase 3. You are phase 1 students. Treatments will do, leave it for coming years, not for this year. Nobody will ask you the treatment. Never stress out yourself how we repair this and how we repair that. How we do the graft, how we do the coronary bypass surgeries and all that. That is for your interest purposes maybe, but not for your exam purposes. We never craft a question where we'll ask a management type of thing. How you'll treat this patient, we'll never ask you. So, This joint, now what is important, we know that this is a hinge type of uniaxial joint. Now I am interested in knowing its names of its ligaments. Can you name its ligaments? You have done it yesterday, guys. I hope you can answer me. Uday? Huh? Radial collateral and ulnar collateral. And? Annular and? See, you are still eating one.
There is the vagus.
No, vagus is a deformity, my dear. Valgus and valgus deformities are there. There is an angulation. That's not a ligament. Don't ever say that. So now still one is missing. Who's that one? Osama, retry. You don't know? I'll give you the answer. I'll show you the answer. Can you see this one? What is that? Is it annular? Capsule is the first ligament of any joint. Capsule is also a ligament. It is. If you don't know it, my dear, wake up. Capsule is the name of one ligament of any joint. If you are asked, name the ligaments of this joint, first name is capsule. So, fibrous joint capsule is the first ligament. Second, and there is a bursa underneath. Is under the skin. We call it subcutaneous olecranon bursa. What is my second ligament? Annular ligament. What is my third ligament? Triangular on the lateral side. I can call it lateral ligament. I can survive. But to be more specific, it's on the radius. So radial collateral ligament is the scientific name. Now on the ulnar collateral. So this is having an anterior band, it has a posterior band, and it has an, don't say transverse, it has an oblique band. These are three components of my ulnar collateral ligament, and they all bands, they make my, and you can see all the images. This is my, so these 1, 2, 3 and 4 are the names of ligaments of my elbow joint. If you don't know it, you are in trouble. This one, the radial, yes, it has, you can figure out here. But this is more prominent. If you compare these two, who's more prominent? Tell me. Khalas. Serve the purpose. Clear, guys?
Is the nerve above the ulnar collateral ligament or below?
Which nerve?
Ulnar nerve.
Ulnar nerve has to do, ulnar nerve is just passing behind medial collateral ligament. So it's going behind. It's not interfering with the ligament. It's just as, because, remember, these ligaments are there, but there is a capsule. Capsule covers things. So the nerve is not interfering, it's just passing here. Okay? In the neighborhood. Now, coming to the proximal radio-ulnar joint, and there you can see the head of the radius and the notch here. We know that whose radius and whose ulna. And then we have these cords, tendons, and there is my annular ligament. Guys, one message. Be careful. Small kids, never in love. Don't pull them from their hands like this. They come to you in love and you are holding their hands and you are just bringing towards you. It may happen they dislocate their shoulder, or this head of the radius may pop out from its normal position, and then you can have a trouble for no reason. Or don't throw the babies in air and try to hold it. Oh, I'm so in affection and love, and baby enjoys and laughs, and you keep on doing it. Sometime it happens, you cannot catch the baby, baby's been dropped, may break his head or a bone and all that. So a happy place ending with a sorrow. And then, sorry, I didn't mean it. Father is angry looking at you. And if you are the father, everybody's, damn it, you don't know how to take care of a baby. So be careful. And if anybody is doing it, respectfully tell him, sir, don't do it. It may harm this little one. This one don't know what can happen next. So annular ligament is very important, and this head of the radius may pop out. Now this joint, what is the axis? Again, when we talk of a joint, we need to know what is the axis of the movement. Axis of the movement for this joint, it goes vertically downwards, and the movement occurring here like merry-go-round. Do you know what is merry-go-round? You all have seen You all have seen when you are a child and you all love to do that and you all don't want to get out of it. Do you remember? Your parents take you to some carnival or some place where there are so many horses and they move like this. Do you want to get out of this? That is merry-go-round. And if you haven't done it, go today and complete your childhood. But they will not allow you maybe. So this movement occurring at this joint in these fashions, in this way or that way. So this is the axis of the movement. And what we bring here, supination and pronation. Supination and pronation. So this is, I mentioned, when it's popped out, this is the name of this condition. Is that right? Now there is a bursa under the tendon of this biceps muscle. So it is minimizing the friction here. Now these are the muscles who brings flexion and extension at the shoulder joint, of the elbow joint. And these are the muscles who bring supination and pronation at my proximal radio-ulnar joint. Is that clear? Don't say supination and pronation are done at the elbow joint. They are done at proximal and distal radio-ulnar joints. Is that clear? Now be ready. What is happening? What happens here, guys? Accident really is an accident? When, Sayara?
The superior brachial
Khalas, we are done with brachial plexus. Finish.
Humeral fracture.
Guys, look at the elbow. And his whole body weight over his elbow. And look at his face. He's in pain. So he toppled on his elbow. Now, this is the X-ray of him. Nothing is wrong? What do you think? Pushed in. Anybody? Gentlemen, you are sleeping. Hello? Why are you sleeping? No. Your back on you. Why sleeping? So, Mohammed is saying nothing wrong. Najmuddin, yalla gum. What's wrong here? Khalas, Mohammed. So what's wrong here? Umar? Yeah. You're not Umar? Arswad? What's wrong? Mohsen?
It's like the head of the nurse is like and
Really? My dear, nothing is wrong. Now you want to see what happens after that trauma? It happens. Now what has happened?
There is now something wrong. I'm sure there is something wrong.
So this is called dislocation and this is like a normal image. Don't waste your time. At your level is fine. So this is dislocation.
We just say dislocation.
Simple dislocation. And what type of dislocation? Anterior dislocation.
Do the tendons of the capsule.
Is it anterior or posterior?
Do the tendons of the capsule regenerate?
Guys, there is a question. Ask loud.
Do the tendons of the capsule regenerate?
Tendons of the capsule, everything regenerates, but it takes time. The bone injuries, joint injuries, they are more painful and their things are coming late. Now, guys, look at it. This is a normal image of any elbow joint. This is a dislocation. And there you can see this is a fracture. So these are three different categories. If you see this has been engaged, that's normal. If you see this has been displaced, that's dislocation. And if you see this has been broken apart, this is fracture. Now these are different fracture ways, mechanisms. Now what's wrong here?
Supracondylar fracture.
Okay, come and show me. Where is the fracture? Mohammed, come and show me. مشوار مرة أنا أعطيك سيارة نبغى سيارة كبيرة لا طيارة نبغى دبابة So Muhammad says fracture is right here. Thank you very much, Muhammad. Sit down. Hold on. If we say there is a fracture here, what about this part?
What about this one? Okay, this is the...
There is a gap here also. There is a gap here also. There is a gap here also.
That's what I said. Okay. But this foot, this is probably the ulnar.
Obviously.
Ulnar dislocation.
This is my, so many dislocations? Really? Alas. Shukran. No, fine. I saw your concern. Anybody wants to change it? Still there is a room for changing.
I think the bone is growing, still growing.
I'll come back to you. Any other idea?
Maybe this is the conflict where the kids had it.
Any other person? Osama? Anybody else here? Yusuf?
No, maybe it's issue of the radial head and the annular.
So you are thinking dislocation. And Tariq? No, there is not possible. You will not find anything in that extent. Trochlear fracture. So you are agree with Muhammad, what Muhammad said. Now, Afan.
And there is some swelling.
There is some swelling. Fine. Soft tissue swelling. Gentlemen, will you like to say your answer again? Loud.
The bone is still growing.
Give a big hand to him. Now what is happening? And there was a fracture. Nobody picked that. This is an X-ray of a person who is less than 25-year-old. The epiphyseal plates, epiphyseal ends have not united yet. This trochlea is a separate bone. This is a separate bone. And this head of the radius, look at it. There is the head, there is a epiphyseal plate, and there is the lower part. Now I can put another image for this that will make it clear to you. Can you see that? Muhammad, you are calling this as a fracture. Actually, fracture was here. And this was again the growing ends. So this is below 25, the bones appear like that. So going back, so don't confuse. Look at why is happening everywhere. It means this is an X-ray of a minor. You know what is a minor?
Of course, but shouldn't I know?
Look, it's not like if you know then it's the authenticated, and if you don't know it's out. No. It's just a challenge. You are in a process of learning. Nobody is born perfect. And don't think if you don't know then it should be out of the book. Torn that book, this book is out. No, it's not happening. We all are here to learn. And my job is to make everybody understand. Look, he answered. He's from the same batch, same level. He's your colleague. Fine? So like he thinks smartly and his idea works. Like your idea works for temperature regulation. And whole class was uploaded for you. Now he deserves that. So everybody can be smart. Only you learn to utilize your thought process. Perfect. I appreciate. So this is happening. And we can able to say fracture is here, but these are actually the bones have not fused yet. It's not, the process has not complete yet. It's a minor. Now, what's the idea here, guys? Now be careful. So again there is a problem here. You can see this bone appears separate. This bone appears separate. This head appears separate. But there is something wrong. This is fracture. So now let's highlight it. There you can see. It's more visible now. This is a fracture line. But this is the capitulum. Trochlea even not visible here. The notch is not visible here. The head, look at it. How radial head? Does it look like this? So again it's a minor. You said right. But why I overlapped? So you can be deceived by looking in these type of images. So develop your thought process to understand all that. Yes, gentlemen.
Why don't we see it?
Because it's not even visible nicely so you can comment on that. It's in the process of reformation. Right? Obviously these type of X-rays we will never put in your exam because we understand you are just our new babies.
Thank you.
And we don't want to kill our new babies, but just to give you a little bit sweat, these things have been implanted. Yes?
How can you differentiate between growing plates and fracture?
You can see it. It's all visible. Obviously with this color it's not. There you can see there's a different part. There is a clear-cut demarcation, and it's not a fracture thing at all. and they are like, it never appears capitulum like this, it never appears head. So more you see, the more you learn, the better you'll be. Is that clear, guys? Now, we talk about this fracture was a supracondylar fracture, and what happens in this fracture? The median nerve and the brachial artery are endangered. See the bone? It acts like a sharp knife, and it really, because this nerve and artery was not close to this bone, but once it has been fractured, supracondylar type of fracture, it's killing this nerve so badly, it's hitting this artery. In this individual, this artery is being traumatized, the muscles in the forearm, they are affected badly, and he develops this type of appearance of the hand, and this is a real one. This is a real picture. This is known as Walkman's ischemic contracture. So if you ever see a supracondylar fracture on an X-ray, and if distal pulses are not present, suspect an injury to the brachial artery. And if you see loss of movement, and you'll be learning it shortly, in the hand, what are the areas of supply which are supplied by the sensory supplies and the motor supply by the median nerve. If you find those deformities, you can simply say, along with this fracture, gentlemen, there is a susceptibility of injury to the median nerve or to the brachial artery. Brachial artery, if you leave it untreated, you're going to land up with this type of hand where recovery is damn difficult. You can see that so many surgeries have been done, but still the problem persists. And this poor person has to live like this. So these are the impact of injuries. Why these location of the fractures are important? Because these are certain structures who are closely related to them. Again, you are looking at a view of supracondylar fracture. Supracondylar fractures are commonly seen in children. Now, this is a fracture at the lower end, and you can see how we fix it. We put plates and screws and all that. So humerus, which was originally distorted, this is how it has been fixed.
Like this is more painful than
Obviously. So there you can see that distortion. This is a normal view of the same person, and this is after damages. Here you can see dislocation. There you can see a small chip is being taken off. So there you don't do much except give him some rest, and he'll be fine. But a fragment, you can see these small fragments, they are chipped off. That's it. Thank you very much.